So good afternoon, dear audience. Please let me introduce my PhD topic, which is about the effects of maternal factors on the development of orofacial clefts. My name is Márton. Currently, I'm a fifth-year dental student here at Semmelweis University. The two of my supervisors are Gábor Varga and Gábor Gerber, and my scientific methodology supervisor is Bianca Golzio. My vision is to decrease the incidence of orofacial clefts and improve the patient's quality of life. And my mission is to indicate which maternal risk factors play a role in orofacial cleft incidence through the newest scientific data. Currently, we have two ongoing meta-analyses now. The first one is about investigating the effects of deleterious habits and maternal health disorders on the risk of orofacial cleft development. It is a systematic review and meta-analysis. So we know that orofacial clefts are quite common birth defects with an estimated worldwide incidence of around 1.7 per every 1,000 live-born babies. And these babies born with these types of anomalies have feeding difficulties. They are often developing conductive hearing loss. They have several dental anomalies, speech problems, and associated social and psychological issues. We know from the literature that maternal diseases during the first trimester of pregnancy are shown to play a role in the development of orofacial birth defects. So that is why our aim in that project is to identify those maternal factors that increase the risk of orofacial cleft development. We have the clinical question of do maternal health disorders and deleterious habits during pregnancy increase the risk of development of orofacial clefts. We use the PEO framework where our population is pregnant women. The exposures are maternal risk factors such as smoking, hypertension, alcohol consumption, diabetes, and obesity. And our outcome is the prevalence of cleft lip and palate and cleft palate only. Our hypothesis is that some maternal health disorders and deleterious habits during pregnancy increase the risk of orofacial clefting. And why is it important? Because using our results, these orofacial clefts will be diagnosed to a greater extent, and the mothers in the first trimester will be more actively treated in order to prevent the development of orofacial clefts. Here you can see our systematic search with the given search key, and we conducted our search in the three databases that you can see here. And after the selection process, we have altogether 63 eligible full text for the analyze. We have the outcomes that you can see here, but due to the strict time limit, I will only introduce just a few of them. The first figure is about the effects of diabetes on the development of orofacial clefts. In all of our analysis and forest plots, we calculated odds ratios with a 95% of confidence interval. Here we included 12 papers, and we used the three subgroups, which are the ND, which stands for not defined. The second one is the CLCP, which is the cleft lip and cleft palate, and the third one is the cleft palate only. So the reason why we use these three subgroups is because from the literature we know that the cleft palate only and the cleft lip and palate, the development of these types differ from each other. So that's why we found important to analyze these separately. And as you can see highlighted, the overall odds ratio is 1.67, which means that those mothers living with type 1 diabetes during the pregnancy have a 67% greater chance of giving birth to a baby suffering from any type of clefts. And as you can see, although in the subgroups the odds ratios are not statistically significant, but combining these odds ratios, the overall odds ratio will be both clinically and statistically significant. The second figure is about the effects of underweight on the development of orofacial clefts. Here our inclusion criteria was that the BMI index is lower than 18.5. Here we also calculated odds ratios, and we included 14 papers and used the three subgroups just as before. And here also it is true that the odds ratios of each subgroups might not be statistically significant, but combining together the overall effect is 1.3, which is also clinically and statistically significant, and it means that those mothers who are suffering from underweight have a 30% greater chance of having any type of cleft baby. And the third figure is about the effects of smoking on the development of orofacial clefts. The size of this first plot is quite big, so I divided it into two slides. Here we compared those mothers smoking during pregnancy versus who are not. And we made the two subgroups according to the type of smoking, active and passive. Here you can see the active smoking with the odds ratio of 1.44, which is clinically and also statistically significant. And the second part of this figure is about the passive smoking. Here the odds ratio is 2.12, which, as you can see, is greater than the active smoking. That might be because, as you can see, we have one clearly outlier, this GIA article. As we investigated that, we found several confounding factors. It is from Asian population, where we know that the literature that in the Asian population, the overall incidence of orofacial clefts are bigger than any other part of the world. So that might be a reason why the odds ratio is so big in that article. And as we combine the active and passive smoking, the overall odds ratio is 1.58, which is also statistically and clinically significant, and it means that those mothers who are smoking during pregnancy, no matter whether it is active or passive, they have 58% greater chance of giving birth to a cleft baby. The strength of our study is that we subgrouped according to the different cleft type, which is new to the previous meta-analysis. We investigated more exposures, and we have relatively high population. However, we have limitations in that study. In some cases, we have low number of articles and high risk of bias in some cases. So, conclusion is that diabetes, underweight, and active smoking significantly elevates the risk of cleft development. The implication for practice is that nutrition, plasma glucose levels should be carefully monitored during pregnancy, and more effective prevention programs against smoking are needed, especially in case of pregnant mothers. And the implication for research, just as I mentioned that the CPO and the CLCP development differ from each other, there is more research needed, what could be the reason behind that. And more research needed to identify those exposures which affect synergistic, because as we analyzed or as we selected nearly 1,000 articles, only just one which were investigating two exposures together synergistically. And here you can see our progress of our first project. We are just about to start the manuscript. And here you can see the two targeted articles of mine. And my second project is about investigating the effects of pharmaceutical therapies during pregnancy on the risk of orofacial cleft development. That is also a systematic review and meta-analysis. We know that, for example, 14% of pregnant women filled at least one prescription for an opioid analgesic during the first trimester in the USA. Maternal corticosteroid use was associated with increased risk of cleft lip with or without palate. So that is why our aim is to identify those medications that might increase the risk of orofacial cleft development in that study. Our clinical question is that do medications during pregnancy increase the risk of the development of orofacial clefts? We also use the PEO framework where our population is pregnant women. The exposures are medications such as antibiotics and anti-epileptic drugs, and our outcome is also the prevalence of cleft lip and palate and cleft palate only. Our hypothesis is that some medications during pregnancy increase the risk of orofacial clefting. It is important to identify these medications that should be avoided during pregnancy. Here you can see our systematic search. We also made our search in the 3 databases, and it is only in the early phase of progress. As summarized, you can see the 2 of the ongoing projects that we have and we are working on. And I would like to thank your attention with the quote of Louis Pasteur: "Science knows no country because knowledge belongs to humanity and is the torch which illuminates the world." Thank you.
Thank you for your presentation. I would like to ask if the diabetic mothers were investigated according to well-controlled or poorly controlled diabetes or is there any effect in the blood glucose levels, or just in the diabetes itself is a factor?
Thank you very much for the question. Yeah, it is quite important. Unfortunately, none of the articles says any additional information about type diabetes, except just these mothers living with type diabetes. But it would be important that somehow categorize these mothers, for example, according to the blood glucose level. Thank you.
My question is about this same topic, that in the papers you were investigating, was there any distinguish between if the mother has baseline diabetes or has gestational diabetes? So is this differ in any way? Thank you.
Yes, so yes, in some article they investigated also type 2 diabetes, type 1 diabetes, and gestational diabetes. And the reason why we only included type 1 diabetes and not gestational diabetes, because gestational diabetes only evolves after the first trimester. And taking into consideration that the cleft palate and the development of the face only happens in the first trimester, so that's why we found that only including only type 1 diabetes is relevant in that study.
You mentioned there are some bias in your research. So how about the data? So were the data collected as self-reports, or for example the medication, where you can perhaps find official data about the prescriptions?
Yes, so we mostly we included case control studies where these mothers were asked by a professional. And referring to your question, recall bias was one of the most important bias, because those mothers who have any type of cleft babies tend to, I don't know, blame themselves, and they believe that, for example, they were smoking or they were consuming alcohol, so that could be the reason why they have this cleft palate baby. Regarding to the second part of your question about medications, as I mentioned, the second project is only in the first stage or only in the early phase, so we are still figuring out how to manage these data.
Okay. And how about the clinical syndromes? Because cleft palate and cleft lip used to be part of clinical syndromes. So have you investigated the syndromes or the syndromatic clefts, or only the separated?
Yeah, that's an important question. We excluded those babies who have any other syndromes.
All right. Thank you for the presentation.
Thank you very much.